Welcome to the License to Lead podcast. I'm Patty Fay. This podcast is for physicians or anyone who thinks healthcare needs a transformation led by physicians. License to Lead means that physicians are charged with and must be in charge of guiding the vision and the culture of healthcare systems. Hi, everyone. Welcome to License to Lead. This is Patty Fay. This is the first episode of our second season, and as promised, the topic today is pharmacy benefit managers. They contract with insurance companies to create and manage formularies. The PBMs, or pharmacy benefit managers, are the middlemen among three entities. Well, there are more than three, but these are the important ones to get us started in the conversation. The first one is the insurance company, or other payers like government programs, Medicare and Medicaid, or self-insured employers. The second entity is the pharmaceutical manufacturer, also known as the drug company. So whoever's making the medications. And the third entity is the pharmacy. That's who dispenses the medications to patients. Smack dab in the middle of those three entities is the pharmacy benefit manager. The PBM negotiates prices of drugs with the pharmaceutical manufacturers, and as a result of that negotiation, the PBM decides which drugs are on the formulary. And the PBM determines whether or not the drug is in a favorable tier or a favorable position within the formulary. And this is just huge, because if the drug is favorably placed, then the drug manufacturer will make a lot of money because the drug will be prescribed a lot. Doctors and patients are steered to use that drug. Now, as a physician, if you don't want to be steered toward a specific drug by a PBM administrator with zero medical training, if instead you'd rather choose a prescription based on your patient's needs and by using your extensive experience and expertise, you will pay the piper for that privilege. You will waste your time and destroy your brain by making one prior authorization call after another to get a drug approved if it's not on the formulary path of least resistance. I already mentioned this, but I will reinforce the fact that the PBM is indeed the middleman, the money handler. So a pharmacy dispenses a drug to a patient, and the middleman reimburses the pharmacy and then collects money from the insurance company to cover, or as we will discover, more than cover what the PBM paid to the pharmacy. The fact that these pharmacy middlemen have the authority to create a formulary and determine the tier that each drug is placed on means they have enormous leverage over the pharmaceutical manufacturers. And they use that leverage mightily with an audacity that is no doubt fueled by a business school mindset. In fact, I think PBMs are highly organized hives housing battalions of people with a business school mindset. Now, in case I'm sounding a hair too condemning, let me quote Aaron Fox, a senior pharmacy director at the University of Utah Health, who was quoted in August 2021 in Modern Healthcare. The University of Utah has an entire pharmacy tech team devoted to dealing with prior authorizations. And Ms. Fox said that physicians and other clinicians are frustrated because they, quote, often aren't allowed to prescribe what would be the best treatment for an individual patient, close quote. The requirement to use step therapy or fail first processes mean that patients have to use suboptimal drugs first and even use their copay for the privilege of doing so, even as their disease worsens. To further corroborate the lack of patient orientation by the for-profit PBM entities, just check out the flood of legislation and the wording used by the state and federal lawmakers as they frantically try to rein in PBMs. One congresswoman told PBM leaders that she didn't know how they could sleep at night given how they jacked up the price of insulin. And another congressman criticized the PBMs for gouging their customers and operating, quote, with a greater secrecy than HBO guarding the ending of Game of Thrones, close quote. He said it was a mystery whether PBMs bring any value to taxpayers at all. While researching this, I got to glow with pride when I discovered that my home state, North Dakota, passed legislation regulating PBMs. Then 34 attorneys general from across the country filed an amicus brief in support of the North Dakota laws that regulate abusive behavior of pharmacy benefit managers. An amicus brief is additional information provided to a court. It's probably a form of piling on by overworked public servants who have been battling these well-resourced PBM lobbying organizations for years. Earlier this year, for License to Lead episode number 13, I interviewed Dr. Barbara McEnany, who is a former president of the AMA, and she's an oncologist who founded the New Mexico Cancer Center. During that first interview, I thought it was so striking when she said, quote, "We've figured out 7 different ways that PBMs make money on every prescription," close quote. And that was so tantalizing that I interviewed her again recently, hoping that she could help me understand this complex topic. Before I wade into the conversation, let me provide a couple things to help with context. Number one, there are 3 big PBMs that are responsible for handling 75 to 80% of all prescriptions in the United States. And these are Fortune 50 companies, not Fortune 500, not Fortune 100. These are Fortune 50 companies. And the big 3 are CVS Caremark, Express Scripts, which is owned by Cigna, and the United Healthcare PBM, which is Optum Rx. And the second thing I want to mention for context is that the secret sauce to the extraordinary financial success of these 3 big PBMs is indeed secrecy. These companies have been unregulated, unsupervised, and allowed to have a truly inexplicable privilege of secrecy. So despite involvement with government programs like Medicare and Medicaid, and despite endless hand-wringing about our shocking level of healthcare spending in the U.S., these companies are able to wheel and deal behind closed doors without revealing what they're paying or what they're getting paid in their various clandestine transactions. This is more than a secret sauce. It's jet fuel, or a license to steal, as my guest today suggests. How lucrative are PBMs? Well, here's a clue. When Cigna acquired the PBM Express Scripts, it catapulted Cigna 52 spots up the Fortune 500 list to number 13. So Cigna had revenues in 2018 of $49 billion, and after acquiring Express Scripts, their 2019 revenue was $140 billion, from 49 to $140 billion in 1 year as a result of acquiring Express Scripts. Okay, time to dive in. And in a departure from my usual approach, I'm going to present this topic in a methodical way. I'll start by introducing Dr. McEnany for her overview about how we got into this pickle, and then I'll intersperse parts of our conversation as I march through the 13 ways that PBMs profit mightily and hurt people. All right, here we go. Welcome, Dr. McEnany. Thank you for being on the podcast again.
Thank you for asking me to join you.
Well, our mission today is to talk about PBMs, and you and I have circled around it before. It's a complicated subject. Sometimes I think the language is a challenge. You know, a pharmacy benefit manager sounds like a role, like a job description.
It was at first. First idea was not a bad idea. When insurance companies saw the prices of drugs starting to go up and recognizing that there's a new drug coming out every 20 minutes, it seems like, overwhelming the insurance companies to be able to figure out whether they should cover this brand drug or this Me Too drug. And if there's 12 drugs that do the same thing, how do you decide which one you're going to pay for, et cetera? So it started out with a reasonable idea. Yes, you need someone to manage the pharmacy benefit of an insurance company and to understand which are the right drugs to select and put on your formulary. But the problem arose with how the PBMs were structured and paid.
That's my signal that we're about to identify one of the 13 ways that a PBM extracts money from the system or does harm. Number 1, administrative fees. This was the original approach when the need for PBMs arose decades ago. The intention was that PBMs would be paid an administrative fee, either based on per prescription or a set fee per member per month. The new transparent PBMs, in contrast to the big 3, vow to use only administrative fees. The new PBMs are receiving a very warm welcome, given the fact that there's legislation in almost every state and on the national scene to address the profiteering tactics of the PBMs, especially the big 3 PBMs, all 3 of which are currently facing racketeering charges. Number 2, rebates, also known as Discounts are the opaque wheelings and dealings between the pharmacy benefit managers and the pharmaceutical companies or drug manufacturers. Here's Dr. McEnany.
So it didn't take long for them to figure out that if they got part of the discount of the drug cost that they negotiated, then it was in their best interest, their economic egoism best interest, to say, well, let's get that maximal discount. Well, what's the easiest way to do that? If your drug costs $100 and you say, I want you to raise your price to $120 and then give me a 10% discount, so there's $12, and I'll give some of it back to the insurance company because they don't know what I negotiated. They'll say, well, I did such a great job for you as your PBM. I got you a $3 discount. And then that other $9 can go into the pocket of the PBM. The items get marked up and then put on sale and marked back down. But the problem is it never is marked all the way back down. It's just funneling a lot of that money into the hands of the PBM and back to the insurance companies. And if that were a transparent process, if you knew what the list price was for the drug, if you knew what the discount the PBM had negotiated, if you knew that the price didn't go up so that you could mark it down, and then the patient gets stuck paying the higher copay because their copay is 20% or a 20% coinsurance, which means the patient is the one who really gets in trouble from this.
Right.
That function, that job description could be useful. But when you take away the transparency, you just create an opportunity that sounds like a license to steal. You can just add more money to the pot and put it in your own pocket. Those PBM discounts do not go to the patients. And when we've tried to pass legislation like we did here in New Mexico to say that a PBM discount has to be delivered to the patient at the time of purchase, the entire insurance industry rose up and said, oh no, then we'd have to raise your rates, which is nonsense. And there's no study that says they would have to raise the rates. They would have to decrease the profits of the PBM. And that's, of course, the direct way that the PBMs make their money and make a lot of their money.
Number 3, formulary manipulation to prioritize PBM profits. So the original intent of using PBMs to create and manage formularies that would actually serve patients and help keep health plan costs under control has long since been corrupted. Physician Robert Levine is the president of the Alliance for Transparent and Affordable Prescriptions. Imagine us even needing such an organization and needing a practicing physician, Dr. Levine is a rheumatologist, diverting their time to tackle this issue. As an aside, I have noticed that physicians are the most passionate and effective advocates tackling the PBM Goliath. Dr. Levine says that formularies are not rational and not focused on what's efficacious or safe. The only thing that counts is, quote, how much money, how big of a truck they can pull up filled with cash to give to the PBMs, close quote. Author and cardiologist Kevin Campbell says that if PBMs switch to another drug mid-year, it's almost always due to a more profitable contract with a different manufacturer. And the result of this formulary change is that patients are forced to give up a stable therapy for a non-medical reason. I don't know, you might think that concerns about correct treatment, drug effectiveness, safety, actual data would be the deciding factors regarding which drugs get preferred status on a formulary. But in the PBM world, it's all about which drugs pay the best rebates, thus increasing profits for the PBMs. And to corroborate these points, here's Dr. McEnany.
But then the PBM, because it has the ability to determine which tier the pharmaceutical companies get their drugs on, which is what their profit is dependent on, they can then go back to the insurance company and use that leverage to really make sure that the amount that goes into their pocket is maximized. So if there's two competing drugs that do the same thing, the PBM is likely to pick the more expensive one, not the less, and to negotiate a nice discount, which they mostly keep.
On this point, I'll put a really useful video in the show notes. In the video example, an insurance company's formulary does not cover a $20 generic drug, but instead puts Nexium on the formulary to treat somebody's gastroesophageal reflux. Nexium costs $148, so why on earth would such an unlikely business decision be made if the drugs are comparable? Well, the Nexium manufacturer provides a $50 rebate to the PBM, and the PBM of that $50 passes $10 along to the health plan, but pockets $40 on each prescription. The result is that the health plan pays $138 for each prescription rather than $20 for the quite efficacious and acceptable generic drug. And in this case, the patient is most likely paying a copay or coinsurance. They could be paying $20 or even $50 in copays each time they pick up their high-priced Me Too prescription, rather than simply using the quite acceptable generic drug, which is $20 but not available on the formulary. Number 4, and this is a big one. One notable source of revenue for PBMs is called spread pricing. This is widely considered to be a shady business maneuver where the PBM bills the health plan for more money than what the PBM paid to the pharmacy for dispensing the drug. So instead of simply passing through their cost of reimbursing the pharmacy, they upcharge and then pocket the difference. The health plan doesn't know how much the PBM paid the pharmacy, so they don't know if there's a so-called spread or how much it is. The surreptitious nature of this upcharging makes it akin to skimming, and if the word skimming makes you think of the mafia, you're in good company. An opinion article in the Washington Examiner was titled "The Sopranos of the Pharmaceutical Industry," with a subtitle, "How the PBM Mafia Works." The author, Kevin Campbell, says that PBMs operate in a world with little oversight and even less transparency. In other words, PBMs are middlemen who are paid on both sides of the transaction, similar to the way in which Tony Soprano and his captains ran their garbage business in New Jersey. He goes on to say that PBMs actually drive costs up by using their middleman position to increase their own profits. They work to negotiate contracts with drug manufacturers, health plans, and pharmacies that maximize their profits at the expense of patients and physicians. A 2018 Health Affairs article reported that a study of Medicaid costs in Ohio found that Caremark and Optum Rx pocketed $200 million in spread pricing. And that's just 2 PBMs, although admittedly, those are 2 of the behemoth PBMs, but that's just in one state with one payer, Medicaid. So it really helps you get quite the picture of how Caremark, Optum, and Express Scripts ascended to the Fortune 50 status in short order. Exploiting these federal programs, which are designed to support people in need, was probably a real boo-boo on the part of the big PBMs. It got the attention of the federal government. Number 5 is the PBM strategy of buying up and controlling processes within pharmacies. It is a humdinger. First, the insurance companies, the payers, needed some help with their formularies, and those vendors were born, PBMs. And then we forgot to regulate them. We forgot to provide clarity about their transactions, and we forgot to insist on transparency so that the business school mindset would be subject to values other than unrestrained profiteering. These for-profit opportunists became such incredible profit centers that any insurance company hankering after huge margins just had to have one. Now, I won't even dive into the complexity and apparent conflicts of interest when the insurance companies own the PBMs, like Cigna owning Express Scripts and United owning Optum. Or in the case of CVS and Caremark, they turned the table and the PBM bought the insurance company, Aetna. But we'll focus here on the consolidation of pharmacies into the PBMs. Here is Dr. McEnany.
So then the PBM has the ability to become the pharmacy. Look at Caremark CVS. So every time a pharmacy sells you a drug, they have a markup on it. They have to, or they wouldn't be in business. Any more than if I sold you an apple for the same amount I bought the apple for, I wouldn't be in business very long. So the pharmacy has to mark up that a little bit, but the PBM gets to decide what the pharmacy markup is. And the PBM then decides what the pharmacy is going to be paid for that drug. And the PBM is often hooked to the distributors, who are the ones where the pharmacy purchases that drug to have on their shelves for the unsuspecting patient to come and purchase. So there's several places there where the PBM can take a fee for distributing it, a fee for acquiring it for the pharmacy, lots of little fees here and there that can add up very nicely.
Number 6 and number 7 are two related, lucrative strategies that replace the need for local independent pharmacies, and they are mail order pharmacies and specialty pharmacies. And Barbara and I talked about them together. Here we go.
And then to really cut out some of the other issues, they can become a specialty pharmacy, and they can demand that patients mail order from them directly. So then they cut out the little ma and pa pharmacy on the corner drugstore completely, but they are a mail order pharmacy, which then means that they can accumulate a lot of these drugs, buy them at a very big discount, mark them up to themselves as the PBM, get the discount from that, and then ship it on out to the patients. And every physician has seen in their EMR somewhere that they get this automatic refill notification from the Sure Scripts of the world or the Express Scripts of the world, wanting you to just refill that. Well, if you had all the time in the world, you'd go back into that patient's chart and say, are they really due for a refill? Is this really what I should do? But there's 100 refills in your inbox, and you're already an hour behind seeing your patients, so you just refill medicines. It happens a lot. And then they made a sale, and if the patient never needs that medicine or doesn't take it, who cares? They made the money, and what they care about is making the money.
I haven't even heard of that one. Is there a name for that particular maneuver?
I don't know if it's named. It's under the guise of making it easy and getting those refills, and it's under the guise of patient adherence. We don't want the patient to run out of those medicines, but the physician has to reauthorize that refill, and therefore they're sending these little friendly reminders to them. So it would be a very interesting study, wouldn't it, to find out how many of those automatic refills actually needed to be refilled.
After our conversation, I read up on mail order waste and what a huge issue this is. PBMs will steer, or in some cases mandate, that patients use their mail order services and then send medications and other supplies that far exceed the amount that the patients need. And this has led to legislation prohibiting mail order delivery of any pharmaceuticals unless the request was actually initiated by the patient. Apparently, patients get constant solicitations by phone or email enticing them to use so-called Amazon-style home delivery and with promises of lower copays. I read a bit of advice from someone who said that whether you're a payer or a patient, if a PBM tells you that this or that process that they're offering will lower your copay, you should run the other way. And why are PBMs so enamored with their mail order pharmacy services? Well, follow the money. They're able to repackage and reprice drugs that are sent out by mail order. They can choose a new AWP, or average wholesale price, for their drug. I've come to the conclusion that the AWP is akin to a hospital charge master. It's a work of fiction that serves somebody, but not the patient. Number 8, direct and indirect remuneration. These are fees that the PBMs collect from pharmacies. And as I understand it, and this is tenuous, DIR fees were originally a way for Medicare to monitor price adjustments to prescription drugs under Medicare Part D, so that Medicare would get money back. If, for instance, rebates had reduced the cost to the PBM, then Medicare could get that money back from the PBM. But now the term DIR is used broadly to cover a number of different fees that PBMs collect from pharmacies. So in quite the sleight of hand, somehow PBMs have exploited a loophole that allows them to collect various fees for various reasons, and also to retroactively demand money from pharmacies. these retroactive demands are usually based on what the PBMs say are quality measures or performance metrics. But listen in as Barbara describes her experience with the DIR fees. Here she comes.
And then once you have the pharmacy that has purchased the drug from you and sold it to the patient at the price that you required it to be sold to the patient, so you've controlled that pharmacy's margin. Then what they do after that is they look at the quality measures necessary for the health plans, and they say, we will take direct and indirect remuneration, which is sort of a meaningless term, that says we are looking at quality measures that you don't even know we're measuring you on and may have nothing to do with anything you do. But if you don't meet those quality measures 6 months after you've given those pills to that patient, we will demand money back. And if you demand more money back for that medicine that's already sold than what the pharmacy was paid for it, the pharmacy is now in the red for a transaction they thought they were making a little bit of money on.
So it's surprise billing. The pharmacy gets a surprise bill.
Right. So I see this in my own practice where we have a small in-house pharmacy. We don't carry everything. We mostly carry chemotherapy and the support drugs and, a couple of antihypertensives and a couple of thyroid preparations, a few things that we often are prescribing for our patients, but we're not trying to be everything. And we're a cancer practice. So I learned that the quality measures that we are being measured on when they take large quantities of money back out of the pharmacy later on, 6 months after the pills have been distributed, were whether or not we were properly educating our patients and enforcing their adherence on hypertension, diabetes, and cholesterol, hyperlipidemia, none of which I treat, none of which I sell the drugs for. I'm a cancer doctor. I'm telling all my patients to eat ice cream.
Barbara, I don't understand this. So it sounds like this is a hit to the pharmacy, and it's a hit to your little in-house pharmacy.
Exactly.
But it would also be a hit to the pharmacy on the corner. And yet they're being hit by behavior of the practice or the physicians, where
the pharmacy on the corner and the pharmacy in a physician's office are both being hit by the pharmacy benefit managers who can reach into their cash register and pull back that money months after the transaction for reasons that are entirely made up.
I guess my point was the pharmacy on the corner can have this DIR, direct and indirect remuneration, that penalty based on Dr. McEnany's behavior.
Yes.
What?
The pharmacist is supposed to be educating the patients on all this too. So my pharmacists who are busily educating patients on cancer drugs are being dinged because we don't educate on drugs we're not selling to the patients. I'm not selling statins for cholesterol. I'm not selling diabetic drugs because I treat cancer, not diabetes and hyperlipidemia. So we don't even know that those are the quality measures. It is basically a wrapped up excuse to be able to reach into the cash register and pull back some money after the fact.
So I can understand in your in-house pharmacy, but the pharmacy down the road, a mile down the road, could get this penalty for the DIR for behavior of you and other physicians in your practice, in your educating patients, or in the level of hemoglobin A1C. Is that right?
We're not even allowed to know what they're looking at.
Wow.
And there's no way to make a bonus, by the way, on DIR fees. There's no way for that pharmacy to say, we did such a good job helping the doctor manage the diabetes that they're going to pay us more. That never happens. It's basically a concocted way to take more money out of the pharmacy till. And that is all it is. It has nothing to do with quality. I've seen no transparency on how they set these processes up. They take it because they can. And you'll notice that there are fewer and fewer corner pharmacies because after this happens over and over again, the little corner pharmacy, the ma and pa pharmacy, will get a letter from CVS or Walgreens that says, we'd like to invite you to join our family of pharmacies and sell your business to us. And then the PBMs controlled that end of the distribution as well.
Number 9, offering healthcare services right in the middle of the PBM-owned pharmacy.
And now if they can put nurse practitioners into those little pharmacies so that you come in because you have a cold or an earache or your blood pressure's out of control, and while you're waiting for the nurse practitioner to prescribe the drug that's sitting in the pharmacy right next to you, you might go and pick up a few items you don't really need in the store. It really is a great way to increase the amount of money that people spend in your pharmacy.
Number 10, data sales.
And then the next way they make money on this transaction is they sell data. So they've gotten the dispensing fee, they've gotten the prescription fee, they have a shipping fee that they've added, they've got this markdown, they've got the DIR fees, but then they can also add data sales. So some of them will sell data back to other insurance companies of what the physicians are prescribing, and they sell the data to the pharmaceutical manufacturer about what physicians are prescribing, and they can make a lot of money with that back and forth.
That also was not on my list.
They're creative. They find lots of different ways to make money.
We might be at 10 different ways. And my understanding from what I've read is these contracts are practically written in invisible ink. I mean, in closed door rooms, nobody gets to see them. Minimal notes are taken. It is so opaque that it's shocking, which is a whole nother story. How on earth did they get the liberty to have those sorts of processes?
There's no watchdog.
The health plans in the first place agreed to all this.
Well, they created them. They're a child of the health plans, and now they're buying the health plan. CVS bought Aetna. CVS is not the corner drugstore. CVS is Caremark, the PBM. That's what bought Aetna. So then you don't even have to pretend to move the money from the PBM pocket into the insurance company pocket. It just stays there. And there's about 3 PBMs in the country that own 80% of the business about.
Right.
The consolidation is remarkable. So a small transparent PBM, and there are 1 or 2 running around that help, like self-insured practices like mine, to be able to manage the pharmacy benefit that we offer our employees. But they're transparent about it. But they're never going to be the big profitable Optum, Caremark.
Yeah. And Cigna with Express Scripts.
Right.
Number 11, clawbacks. Sometimes a patient's copay is actually more than if they did not use their insurance at all when they go to pay for a prescription drug. That's good news financially for a PBM. So when a patient overpays by using their copay, the PBM demands that difference back from the pharmacy. And what keeps the pharmacist from simply telling the patient, hey, lady, don't use your copay? It's number 12, a gag clause. Here, I launched the discussion about clawbacks and gag clauses. And then a clawback, we didn't specifically talk about that, but the patients come in and they think they're part of a health plan and they're getting a drug cheaper because they're part of a health plan. So they pay their copay, but as it turns out, their copay is higher than it would be if they walked in and said they didn't have any insurance and they just want to buy this prescription medication.
Not always, but on occasion.
Okay.
And some of the early transparency laws have required the PBMs to take out of the pharmacist's contract the clause that says you cannot tell the patient if it would be cheaper for them to pay cash than to submit their insurance. But there are a number of drugs where it is cheaper if the patient pays cash. It's cheaper than their copay.
Right. And if the patients don't know that and the pharmacist
are prohibited from telling them by contract.
They've got their gag clause. So the patient pays more for their copay than the drug would actually cost. And then the PBM pockets the difference.
Correct.
And number 13, prior authorization. Scott Howell, the lead author of a 2021 study published in Health Affairs, said the existing evidence suggests 2 things. Drug utilization management has reached a level that no longer aligns with clinical guidelines. And second, drug utilization management contributes to delays in treatment, use of suboptimal medicines, medication abandonment, and worse health outcomes. Here's Dr. McEnany.
The insurance companies and the PBMs require the prior authorization process, which costs the average physician about $75,000 per year per doctor to comply with. And it frustrates physicians no end when they have to justify their choice of a drug to someone who is just reading from the formulary and says, I'm sorry, that's not approved.
Is that more of a function of the PBM or the health plan?
Both.
Okay.
The PBMs administer it.
All right. The prior authorization process is frequently referred to as contributing to physician burnout. It's one of those big barriers to providing excellent patient care. So, does it actually save any money? In a 2021 Health Science Journal article titled An Estimate of the Net Benefits from Prior Authorization Policies in the United States, the authors stated healthcare costs associated with prior authorizations exceed the benefits of reduced drug spending, increasing total healthcare spending by $1.9 billion per year. Dr. Jack Resnick is a dermatologist, and he's the incoming president of the AMA. And he was quoted in a Medscape 2021 article about a patient that he had that was affected by a prior authorization requirement. He had a patient with a severe skin disorder who couldn't work until a biologic treatment transformed the patient's life, and the patient was able to go back to work. But a year after Dr. Resnick's patient started the treatment, the health insurer would not authorize the treatment anymore because the patient was not experiencing the same symptoms. And of course, Dr. Resnick said symptoms were gone because the treatment was working. So that was 13, an unlucky number for patients, physicians, the U.S. economy, and anyone on the caring side of U.S. healthcare. The time was nigh to wrap up my conversation with Barbara, and I let her know how much I appreciated all of her time.
I'm happy to do it. And the reason I do it is I'm hoping that if more and more people understand how these large corporations, and they are now huge corporations, are ripping off American patients, that we will actually force Congress to do something about it, to enforce transparency laws that have teeth. I mean, finding somebody $300 a day when they're making billions is silly. You know, you just pay it. So why don't we actually require some transparency there?
And do you have a call to action for listeners as far as doing something to make a dent in this fraud that's being perpetrated?
Make sure that you understand it. Make sure your employer understands it. And if you are the employer, ask your health plan when you're contracting to purchase health insurance for your employees, whether or not these practices are going on, and try to carve out the pharmacy benefit and use one of the small non-predatory benefit managers for that.
Yes. And I've read about 2 or 3 of them, and I'll put those names in the show notes. The ones who flat out charge an administrative fee for their PBM services, and they are utterly transparent with what they're paying.
Right.
What an education. I appreciate you being on the podcast with me.
Thank you very much for inviting me.
Thanks again.
All right. Bye-bye.
Thanks for listening to the License to Lead podcast. Be sure to visit licensed2leadpodcast.com to join the conversation, access the show notes, and sign up for our newsletter. Leave us a message with your provocative question or your thoughtful comments. You might inspire a future episode of the License to Lead podcast. Thanks so much, everyone.